Thank you very much for that, Dr. Goldenberg. Thanks everyone for coming today. So I realize the title of this talk is quite grand and covers a wide range of topics. So I did want to, in my objectives, to try to clear things up as to what specifically we'll be talking about with regards to prostate cancer and biomarkers. Now, the word biomarker is a very common term used to describe many different types of tests in many different clinical settings, and so I'd also like to refine that definition for the purpose of this talk. There we go. So the overall objectives today is to first review the need for biomarker development in prostate cancer management, and this will focus predominantly on the role of PSA screening and prostate cancer screening, and whether new biomarkers or new markers of disease can increase the specificity of our current tests in order to reduce the harms associated with overdiagnosis and especially overtreatment. Again, it'll be a focus on PSA, which is the main biomarker of prostate cancer, if you will, and discussing the role of PSA in screening and some of the nuance and the new forms or types of PSA that have been described that might increase the specificity of this test, specifically in the screening population. And then finally, as the last point, I want to briefly, and I underline briefly, review how certain elements of prostate cancer carcinogenesis, specifically the ideas going along with epithelial to mesenchymal transition of prostate cancer cells, can result in clinically relevant biomarker discovery that can help at certain clinical time points along the prostate cancer continuum. So the first is the need for biomarkers in prostate cancer. There are many clinically relevant areas of prostate cancer management that are lacking in our ability to accurately predict which patients, for example, might fail active surveillance, which patients, for example, might have a clinical recurrence after biochemical recurrence, and are there markers that can help stratify patients and give us a predictive value to see which patients would benefit most from a particular therapy or when to pull the trigger on a particular therapy. These biomarkers, there are thousands that have been described to date specifically for prostate cancer, but for a biomarker to achieve clinical significance, there's quite a bit of rigorous validation that's required on multiple levels, and this results in few biomarkers that actually make it through that process to become clinically relevant. And then finally, biomarkers need to be cost-effective, minimally invasive. They have certain characteristics that must be met for them to be a good test and something that can be clinically applicable. I just copied here at the bottom one of the segments from one of the papers in European Urology that was talking about the difficulties with prostate cancer and biomarker, just to highlight what they describe here as intellectual property being one of the major issues and hindrances to clinical validation of biomarker development. And it's simply the fact that, like any drug development, there's quite a large amount of initial investment that is required, and thousands of potential markers that are required in order to bring one to clinical significance. And this alone has resulted in a slow development of these markers.
Can I ask a question? You're saying that the process of IP, patent protection, actually slows the development of biomarkers in the clinic?
That's what the general consensus I've been reading in the literature seems to be, that there's many that are described and it ends there, and that for a company to undertake a clinically useful and validated test that can be actually brought to the clinic requires a lot more rigorous tests from the initial description of that marker.
Process of IP protection is necessary to allow treatment to operate down the road.
Certainly, as well. There's been advantages for sure, but some authors have argued that it does tend to slow down the process of getting markers clinically validated to clinic.
Without that, you can't get the investment to actually create the higher levels of evidence to show that it actually is a valid.
No, it's certainly required for sure, but there was quite a few papers that I came across that seemed to have that angle, that seemed to say that issues regarding intellectual property and proprietary development can actually slow down the development.
Step beyond the IG, right, but nobody's going to take it to the next level.
Well, that's a very good point, and I'm sure that is the case because there are literally thousands of markers that have been described in all different settings, but very few of them obviously are used day to day to guide clinical decision making. Biomarkers as a whole, though, have been defined quite broadly as well, and it's anything that can be objectively measured, and it can fall within many categories, ranging from just clinical parameters like age, ECOG status, etc., which have been used as good markers in certain settings, and as well the classic lab measurements that we're aware of. And as well, nowadays there seems to be a larger push for imaging as a potential biomarker, which I don't want to focus on this talk at all, but it's certainly gaining popularity as well. And then finally, what I'd just like to touch on nearing the end of the talk is the molecular and genetic determinants as a biomarker in terms of answering clinical questions. And so, as I mentioned, the development of any biomarker has to go through analytical validation to ensure that the test can be reproduced, that there's consistency in the analysis, the same acquisition and assessment of the tissue sample is performed. And then there's clinical validation. And that question is really asking how much does this biomarker move us forward in terms of increasing our specificity at a clinical time point for a clinical question. And usually these biomarkers are compared to already existing nomograms that have the highest predictive accuracy to date. So just very quickly, there's many different types of markers. Obviously, this is just a few samples that I just pulled off, and where they can be sampled from. The biomarkers can be discovered within tissues, as in cellular markers, staining for different markers that can predict either treatment response, treatment failure, etc. And then there's also biomarkers that can be measured in blood and in urine, and as well a very popular topic nowadays in the past few years have been genetic markers and different polymorphism panels or different, for example, mRNA microarrays that can predict and can bring some clinical relevance, especially in the setting of CRPC. So this is from that same paper, I believe, Dr. Gleave, and the authors were stating that, oh no, some different paper, but these authors were also arguing that the number of biomarkers per se is increasing in the literature over time, but the actual number of, and this, I believe for them, this was FDA-approved plasma protein markers over time seems to be decreasing. And again, they draw the divide between the development of a biomarker and then its actual clinical applicability as being a major hindrance to development. The Prostate Cancer Working Group 2 in a recent publication also outlined what they were looking for in terms of biomarkers and how biomarkers can be used to answer those clinically relevant questions. And they grossly broke them up into 3 different phases. Those are biomarkers that can help stratify patients or predict patient response prior to treatment, and then 2 types of biomarkers that can be used after treatment. One as a test to determine the patient's response to a particular therapy, for example, and PSA has obviously been used for this in many settings, and then one that can be used as a particular time to event analysis. If a patient were to fail a therapy, for example, can a biomarker predict that before the patient actually fails that therapy? You know, obviously, staging of cancer is done majorly by the TNM classification system, and there have been biomarkers that have been added to this type of system, the first of which was testicular CA, adding its tumor markers. But for most other diseases, most other cancers, it's still an anatomically based system that is describing and assessing the tumor burden of a particular patient. And the question is whether any type of marker that falls into these categories can be added to that in order to increase our specificity of diagnosis. Now again, there's distinct clinical time points where certain biomarkers are useful, and they obviously lie along the disease continuum of prostate cancer. And we've discussed these key stages where a biomarker can help guide our treatment of patients. And these markers are usually assessed via receiver-operator characteristic curves, which determines the area under the curve as a measure of how specific and sensitive the test is. And the ideal test would have a high number of true positives with a very low number of false positives, so high sensitivity and high specificity. And what we are seeing is that many tests, including in some series PSA, is not trending towards, it's not moving the curve towards the left here. And the question is what can be added in order to increase our diagnostic specificity. So the specific milestones in prostate cancer, and the focus will be predominantly on the first two, is in prostate cancer detection and staging. The first would be obviously a marker that can help differentiate benign versus malignant disease with the overall goal of reducing overtreatment. And that's not necessarily related to prostatectomy as well, but also related to repeated truss biopsies, which in themselves carry certain risks, certainly. In terms of cancer staging, can the staging accuracy be improved such that patients that may go for surgery and end up being upstaged, would they be held off from surgery and given some type of neoadjuvant therapy? And so there's a lot of different nuance here of where the need can lie. And finally, in the terms of cancer recurrence, one of the major topics of interest has been to differentiate which patients presenting with a biochemical recurrence actually will develop clinical metastases, and which patients may have a BCR but never actually present with clinical mets. Now, the role for PSA in screening, which was very popular earlier on, we now know it's declining quite a bit, and it's generally not advocated for. It's certainly in certain age groups, and there has been a description of certain different types of PSA, the most popular being free PSA, in order to potentially increase the specificity of prostate cancer and increase the diagnostic yield. And this type of research has been most important and most beneficial within that diagnostic gray zone of patients that have a PSA between 4 and 10, a normal DRE, and the question of whether they should proceed to biopsy or not. Now, the AUA has 5 guideline statements on PSA screening, and it's usually stratified by age. I think we'd all agree under 40 years of age they do not recommend screening, and they say recommending against it. Between the age of 40 and 54, the language is a little bit less clear. They say that biopsy is not recommended, but not that they're necessarily against it, and they acknowledge that in this age group that screening for PSA can identify the rare patients that do have clinically significant cancer and would allow for earlier intervention. Finally, between the age that's been most studied, which is 55 to 69 years in certain large screening trials, the recommendation now is for shared clinical decision making based on personal values, life expectancy, etc. And if a man were to move forward with screening, the interval of screening for PSA can also be extended, as opposed to yearly. They say that screening every 2 years is unlikely to increase the harm of missing a clinically significant cancer, missing a window of curability on a clinically significant cancer. And then obviously if the man is greater than 7 years or a life expectancy under 10 to 15 years, PSA screening, the benefits of PSA screening are certainly diminished in that value. Now, the ER-SPC trial did show a positive predictive value of PSA to diagnose cancer on biopsy of only 25%, which means most biopsies obviously were performed for negative cancer diagnosis. Just to summarize those results here, the number of men needed to screen to prevent 1 death when they adjusted for the difference in compliance in the 2 arms is still over 1,000 men, and over 48 patients would need to be treated to prevent one death from prostate cancer. And again, the shift is to try to see if there's ways to bring that number down without losing those clinically significant cancers that would then be that might lose the window of curability.
That was before they factored in active surveillance.
Yeah.
So
Oh, yeah, that's true.
you factor in active surveillance, so never needed to treat those two non-functioners.
Mm-hmm.
Used to independent.
It's not just death, though. You're not just preventing death, you're preventing morbidity of advanced disease as well.
Certainly.
There's a lot of men who are dying with their death being attributed to non-prostate cancer deaths.
Mm-hmm.
Yet they have significant morbidity over the last few years of their life. That never comes out in any of these studies.
Mm-hmm.
We see it clinically.
15 years of hormone therapy, radiation, and you end up dying of cardiac death.
Yeah.
You're not in prostate cancer death. So,
Mm-hmm. Oh, certainly. And so it was free PSA that initially, brought excitement to the PSA world in terms of increasing the specificity of cancer diagnosis. And so just to quickly go over that paper, it was men between 50 and 75 years that had PSA in that diagnostic gray zone, 4 to 10, with a normal DRE. The biopsy protocols in a lot of these studies and a lot of the larger screening studies of the 90s, unfortunately, were sextant biopsies, so the numbers would change if modern biopsy protocols were applied, especially saturation biopsies. But in the study, as we all know, free PSA, the lower number of free PSA tended to diagnose more prostate cancers. And what was more, within the patients that underwent therapy for their prostate cancer, if the percentage of free PSA was under 25%, that was predictive of more clinically significant disease. The other way was a PSA greater than 25, free PSA greater than 25%, patients tended to have lower grade disease, lower volume disease, and organ-confined disease, and what some would consider clinically insignificant cancer. Again, the area under the curve, when plotted on the receiver operator characteristics, did push did improve the sensitivity and specificity of free PSA. And so there's been a lot of elucidation of the biology of PSA in order to give some justification as to why certain specific PSA assays like free PSA might actually reflect a more pathologic process versus a benign process. And essentially, this is the current understanding of many of the different types of PSA. And we know that the mature active PSA, the vast majority is bound in the serum, predominantly into alpha-1 chymotrypsin, but then the free PSA has been broken down into several different variants of PSA, and these include these pro-PSA isoforms, which is a leader sequence up to 7 amino acids on the N-terminus that prevents activation of the protein, as well as iPSA, which is considered intact PSA, which is a inactive form of the mature enzyme, but still 237 amino acids, and then BPSA, also called nicked PSA, which undergoes internal cleavage, rendering it inactive. And these can all be measured as constituents of the free PSA fraction of PSA. And all these genes are found at the same locus on chromosome 19, and many of them are under androgen control, obviously PSA. And of the free PSA fraction, it's been shown that these pro-PSAs with these leader sequences tend to be the major constituent, but still where the concentrations are in the nanograms per milliliter, or picograms per milliliter, an order of magnitude less than that measured for PSA. So obviously very refined lab techniques are required to identify and differentiate amongst these. Some studies have again shown that the benign PSA or the nicked PSA tends to be expressed predominantly in the prostatic transition zone, and therefore may reflect more of a benign pathology when it tends to be elevated. Whereas the pro-PSA, and there's different types of these depending on the length of the leader sequence at the end terminus, that seems to be produced more in the peripheral zone, obviously where most cancers arise. And so that gave some reasoning as to why these different variants of PSA can be used in such a way. And so free and benign PSA have been associated with gland volume, while intact PSA and human kallikrein-2, which is one of the enzymes that catalyzes the cleavage of the leader sequence, have been associated with tumor volume. And again, whether this can yield any additional clinical significance has been studied by several groups. The first is using a kallikrein panel, which consists of the human kallikrein-2, free PSA, pro-PSA, and total PSA, in order to see whether the area under the curve of our models can be pushed towards the left, and can we prevent unnecessary biopsies by employing a more rigorous screening test. And so in this study, they had over 1,000 patients. They had patients from the Rotterdam study of the ERSPC trial, for which they had blood samples for. And they had 3,400 patients that had an elevated PSA, of which just under 3,000 were biopsied with serum available. Again, the biopsies in these protocols were sextant biopsies, so there is that possibility of simply missing tumor due to fewer cores. And when they applied their kallikrein model to both a lab model, which is age and PSA, and a clinical model, which is age, PSA, and DRE, they showed that adding these kallikrein, adding the full panel, helps shift that curve towards the left, increasing the area under the curve and potentially reducing the number of unnecessary biopsies that would need to be performed. These authors with this model here argued that they would do 307 less biopsies using a clinical model with the kallikrein panel in order to increase the specificity versus just the clinical model alone. But in doing so, they would miss 66 patients that would have cancer, of which 12 of those would have a Gleason score of equal to or greater than 7. So obviously, when you try to play with those receiver-operator characteristics and to determine the ideal value, there's always the chance of losing and missing potentially clinically significant cancers. And that's the big question of how many of those cancers would be lost and how many of those cancers would actually lose the window of curability. And the general thought is that the window of curability would not be lost on the majority of them, according to these authors. A similar group also used the same kallikrein panel to see whether it can substitute for TRUS estimated gland volume, which is obviously a well-described parameter for assessing prostate cancer risk. And they again used several models, beginning with the gold standard model of just PSA, DRE, and TRUS, and then they compared that to different combinations of their model added to that gold model. And in their experience, again, they once again showed that they're able to shift the area under the curve towards a more specific diagnosis in both any cancer and in patients that had high-grade cancer. They also go on to say that their kallikrein panel, just as itself, does correlate with TRUS estimated gland size, and they conclude, which is a little bit of a stretch, but they conclude that this test could actually replace TRUS in terms of assessing prostate gland size, and is therefore much more acceptable to patients and much more readily available to do as a blood test, as opposed to organizing a specific imaging study.
TRUS is an indicator of volume, or is it to replace biopsy?
No, TRUS is an indicator of volume to assess cancer risk. No. So if the panel they determine a cutoff of that panel to reflect what the average background incidence of cancer is. And if the value is above that, I forget what the actual value is, then they use that as the trigger for biopsy. And their argument is that that is equally as good as performing truss to estimate the gland size to determine the risk of prostate cancer.
Trust now you're talking about how does trust volume determine the risk of prostate cancer?
PSA density. Yeah.
Or
Comparing to something that isn't a gold standard.
The truss biopsy, the truss volume, you mean?
It's a factor, but it's not
No, it's not the main one for sure, but I think what the authors were trying to say is to see whether these markers can help eliminate even a truss study in order to really be as less invasive as possible with the same discriminatory ability. So the other form that was described earlier is using the -2 PSA, which has been described having that 2 amino acid leader sequence as also being helpful in that diagnostic gray zone in determining whether a patient should undergo biopsy. In this study, it was a prospective study, and all the institutions involved use a saturation scheme ranging from 18 to 22 cores. And so this study, as opposed to the other ones, really hopefully gets that adequate sampling of the gland and not just missing a tumor because of inadequate cores. And in their study, they once again showed that using that -2 PSA, as well as something called the prostate health index, increased the area under the curve most significantly in terms of trigger for biopsy in this population of unscreened men. And they compare it to free PSA and several other PSA measures that have been used to try to improve the specificity of PSA and show that this prostate health index, which is a score calculated from these same kallikrein markers, as well as the percent of the -2 PSA, have the highest area under the curve. And in this population, I didn't note it out on here, the average PSA in total PSA in the group that did not have cancer and that had cancer was not significantly different. And so it was only when looking at these specific variants of PSA where the differences were apparent. And so many other biomarkers have been described in a similar fashion, and I had reviewed some of them, but they all are trying to show that their model, when you add their specific biomarker to the clinically established models, that they increase the diagnostic specificity and they reduce the number of false positives, or sorry, negatives at biopsy. So certainly, as pointed out, the further clinical validation of all these types of tools are required, and the significance of them is certainly a question. And what I was trying to focus on is that these markers being clinically significant, and using that -2 PSA or the prostate health index, if that is able to tell the patient that you have a higher risk of having prostate cancer based on this test, and therefore trust biopsy can be justified further, especially considering its potential harms, that would improve clinical decision making. But obviously validation is required of these studies. These are all smaller studies, and they're not randomized control trials, are not the highest quality evidence. But they do show that we can refine PSA in order to increase its diagnostic specificity. And once again, in that diagnostic gray zone of 4 to 10, additional tools are required to identify patients but minimize the harms. And then the final point that I wanted to talk about was quite quickly review a specific aspect of prostate cancer carcinogenesis. And at this stage, where I wanted to focus more on after prostatectomy in terms of monitoring patients. And we know that certain markers, PSA-based, have been described, namely PSA doubling time, after RP in order to determine clinically significant metastasis following biochemical recurrence. But can other markers help in a similar fashion aid to stratify patients? This was a study I just wanted to include tangentially, and it was a study of using dogs in order to diagnose prostate cancer based on a urine sample. And these authors had remarkable results. They trained a dog for 2 years in a formal setting. It was a specific dog that's bred for those purposes. And the dog was able to identify prostate cancer, urine from a gentleman, from people with prostate cancer versus urine from control samples with a very high specificity. It was remarkable. And they said that this has been shown in other malignancies, predominantly melanoma and breast and lung as well. And they're wondering whether this can be applied to prostate cancer as well. And I include it because it has technically the highest specificity versus any other test that's been described to date. But obviously it's just a very interesting paper. And the authors do hypothesize that the dog had the ability to smell these volatile organic compounds that may be produced by the altered physiology and altered metabolism of a malignant cell. And there is some evidence for this, and I didn't review these papers in great detail, but there's a general feeling that these volatile compounds that can be detected either by spectroscopy or perhaps by these dogs are genes that are related to the process of carcinogenesis, which affect genes related to the cell cycle, cell adhesion, cell differentiation, and cell immune responses. And this has been characterized very well in prostate cancer, and the main field that this has been under, which is studied here as well, is epithelial to mesenchymal transition, which states that in the primary tumor, the malignant prostate cell undergoes differentiation to a more mesenchymal phenotype, which promotes those markers of aggressiveness, being ability to metastasize, ability to evade the host immune system, etc. And as this occurs through the process, the genetic changes that ensue in this process reflect metabolic changes that then can actually be detected in those VOCs that are produced by this highly malignant and highly active cell, which is turning over many molecules, often with aberrant expression. The particular genes themselves that get altered in this process have been described, and this is a large area of research, especially if you search for biomarkers within this field. There's thousands of papers that come up, and obviously many of them have no clinical relevance at all, but they do describe these changes that occur in the cell that provide potential markers for future development of biomarkers. And the main ones, as I mentioned, are cells related to epithelial markers that are lost as the cell appreciates and gains a mesenchymal phenotype, and therefore loses many of the characteristics that correlate with increased Gleason score, as the cells lose gland architecture, for example, and the cells become more individual or just are found in sheets or have a cribiform nature, which is more reflective of this process. So one of the ways to characterize these types of proteins then is using mRNA expression profiles, which have been done ad infinitum to many different cell lines. And this is just one particular example where authors took prostate cancer lines and did an RNA expression profile, and then did one on benign prostate tissue as well, trying to investigate which genes are differentially expressed in the benign versus malignant type. And this is just one list. There's hundreds of these lists of putative genes that are involved in this type of transition and can be used to follow this type of transition and eventually to determine risk. This particular assay was a genome classifier, which is actually from a local company in BC here. And I brought this one up because it was done in a similar fashion, in that it modeled all of the different mRNAs from 545 patient samples, and it worked down to identify a cohort of 22 genes that the authors state were significantly different from benign disease. And these types of genes, again, are those that are reflective of the immune response, controlling the cell cycle, controlling cell proliferation, and controlling cell adhesion, which are all these markers that we are familiar with that change, and as the prostate cancer changes to a more aggressive phenotype. And more recently, these authors then applied this genome classifier to a high-risk prostate cancer population. And this is one of those studies that I thought was bringing it back to clinical significance, identifying many genes, doing mRNA assays, identifying a cohort of 22 genes that may reflect differences between benign and prostatic malignant tissue, and then applying this to a clinical question. And for the study that they presented, they looked at patients that had a biochemical recurrence after prostatectomy. And they wondered whether their gene classifier could help stratify people in the group that had METs and no metastases, in order to assess at the time of prostatectomy who will likely progress to clinical metastases and which patients, despite having a biochemical recurrence, would not present with clinical METs. And once again, their gene classifier, the results are positive and somewhat striking. They do show that when the gene classifier, which gives a score between 0 to 1, and which is an output of those different 22 genes, when it suggests that there's a high risk of clinical METs, it was quite specific. And on multivariate analysis, their genome classifier, when controlling for the other characteristics of the study, it was the only marker that was significant as a predictor of metastasis. And the authors mention in the discussion, but they don't describe it here, I don't know why, that PSA doubling time was also an individual predictor of metastasis, which has been well described and well shown before. So these authors show, and they have several other papers that state that the genetic environment and the genetic markers of the primary tumor can help predict metastatic progression and the change in clinical status down the road. And this is something that one would have available to them right away, and that the prostate gland would be available and samples would be available. And they were able to take paraffin-embedded samples that were years old and determine their genome classifier on this. And so this is one of those examples of a biomarker that identified these putative type of genes and then brought it to a clinically relevant question in order to answer that question. And once again, just showing, as I said before, that the markers need to be compared to the established nomograms, or the established models. They added their genome classifier to the Stevenson criteria, and once again showed that the Stevenson criteria, when added to them, they had the highest area under the curve compared to all the other variables that they looked at, which were other scales like the Capra scale, as well as clinical factors. So that was just a brief look at how the basic science and performing these gene assays to determine what type of genetic changes are actually taking place on the cellular level can be brought to a clinically relevant question. And so it's a good point, as you say, Dr. Cleve, what types of influences, because it is a proprietary test that was brought to clinical significance here, and what are the issues that are preventing it from being adopted more widely, or that are preventing it from being applied more broadly, to see if it can be validated on an even larger scale. And the authors of those papers focus on the fact that tissue specimens are readily available at this point, and so blood tests, for example, doing this is even less invasive than doing a blood test for the patient, and if it can yield even more information about the nature of the disease, especially in the surveillance setting, it might be very useful.
Most of these biomarkers are taken data in the post-radical prostatectomy specimen. And so that's where the tissue is available. So they're predicting recurrence post-prostatectomy.
Yeah.
Where the unmet need is actually quite low. there. PSA is exquisite, binary, as a marker of treatment failure or treatment recurrence.
Mm-hmm.
So the problem is taking that and now moving it upstream to the neurobiopsy. And many of the people developing these take that leap to say now that we've shown post-prostatectomy, maybe we can use it to risk stratify in the neurobiopsy population in treatment. Maybe do that.
Yeah.
And so you've got challenges with now taking these biomarkers into neurobiopsy specimens, which are much smaller,
Mm-hmm.
and have challenged by heterogeneity and sampling error, which make then prediction to natural history more difficult. It's just an example of the challenges of biomarker development in that highly heterogeneous tumor like prostate, challenged by death from so many other causes. We'll discuss it after.
Yeah, certainly. But just to reiterate that, as you mentioned, at this point, tissue is available, and doing this assay on this tissue can help you stratify patients before the biochemical recurrence even occurs, and let you know that those that, for example, if you do this genome classifier, those that do recur with biochemical recurrence, this particular group has a higher chance of clinical metastasis.
The Kool-Aid of the company selling your selling your product. I mean, the question is, do we care if we're going to identify a guy who may be a PSA recurrence 3 or 6 months early? You spend a test that costs $3,000,
Mm-hmm.
Which is what these biomarker tests cost, to identify a guy who may be at higher risk of a PSA recurrence. And all you have to do is repeat his PSA in 6 months and see if he will recur.
Mm-hmm.
And treat that.
So the idea is that adjuvant treatment would be better than salvage treatment. So
It's an
that's
idea.
Yeah, well, I mean, it's a start. The second thing is that a lot of men with PSA rise will live a long time without actual clinical disease recurrence. And so this test picks up the men who are going to progress rapidly to metastatic disease.
Maybe, but you haven't shown that.
That was the very first study was picked up men with no recurrence, PSA recurrence, but no next within 5 years, and patients with next within 5 years.
So that's when you have to apply that to a validated population prospectively, not to a cohort that we've pulled it out retrospectively. And the adjuvant versus salvage question brings up anytime you're going to treat adjuvantly, you're over-treating a significant number of people.
Well, that's
And
but the biomarker, the select the ones who really need it. And you could use it in a clinical trial to select patients who you think are at higher risk. It's a concept. It's not.
yeah,
The huge unmet need, and you touched on it in the whole first part of your talk, is who needs a biopsy, and then of those who have a positive biopsy, who needs treatment. Once you've already treated a whole bunch of people, that's a smaller group of patients who've already
certainly smaller.
now have PSA recurrence. The unmet need, the relative unmet need, is very small compared to the first two groups. And I think the thing that's going to catch us completely in a landscape change is the role of MRI in predicting for biopsy, which isn't even a biomarker, but it's going to help us determine perhaps more useful than any biomarker.
Sure.
Who biopsy, and that may make the biomarker question in the traditional sense less relevant.
Mm-hmm.
The other part that's coming out is the problem with take this as the problem is with the cohorts of biomarkers expression profiling is they are actually genome DX, DXs, all these other genomic health are grouping based upon expression profiling, and that's promising. The question is, are they going to move the ball enough for their problems?
Yeah, certainly.
An interesting concept that's coming out that gets around expression is genomic noise, and this is what Rob Briscoe is doing. Is the percentage genome altered may help to quantify genomic noise bit better than some of the expression profiles are doing. That's increasingly applied now to the active surveillance or biopsy population.
Yeah.
Unfortunately, none of these are at a place, I think, where we're ready to spend the dollars to apply them.
Oh, that's correct. And there's several other markers like this, and as Dr. Black mentioned, one of the big points that the clinical things that they're trying to address, the clinical point that they're trying to address is which patients at the time of prostatectomy might be better served with early adjuvant intervention, the patients that would require it anyways down the road, and if they can be treated earlier, can that help delay that progression to clinically significant mets, and can this help stratify those patients? So there's similar papers to that effect, all describing a similar concept of stratifying patients at the time of prostatectomy. Dr. Bidnur?
Just a different question. When you do this research on tissue after radical prostatectomy, and you're identifying candidate genes or biomarkers, do you know from that research methods, do you know what cell these things are coming from? It's going to be a mixture of epithelium, smooth muscle,
Yeah.
Blood vessel, nerve in there. I'm imagining that they just sort of process the entire thing with some kind of
I think.
slurry, and then out comes the.
I think so.
And it doesn't even matter if it's coming from the epithelium.
And it very well may not, because they're using that, according to them at least, they're using that same process on then their control tissue. And so if the differences that they're appreciating and then translating to a clinical question, might still hold, because it's relative to the benign tissue that doesn't seem to have that same profile.
Because I had this sort of image in my head that any candidate biomarker is going to be relevant to the biology of the cancer, but it might not be.
No, it's true. It might not be. In the end, it might not be at all.
I think it's one of the biggest problems with all these real-time PCR or expression-based profiling is that if you're going to take a needle biopsy and extract an anti-RNA from that, you're extracting anti-RNA from a small epithelial cancer component, surrounded by a lot of stroma that's benign. And a lot of their initial studies were done for microprostatectomy specimens where they could macro dissect out or select out larger volumes of cancer and get around the homogenization dilution that occurs from amplifying RNA from surrounding benign stroma.
But the authors of the earlier papers would say that even that, when isolating the tumor itself, would still contain tumor stroma, correct?
So then you have to rely on the fact that the tumor stroma is expressing a cancer-specific transcriptome that is also predictive. I think that the genomic, the DNA alterations are not susceptible to stromal dilution. And so looking at percent genome altered gets around the problem of expression changes that are dilution because of the benign components, which will be important as you go to a needle biopsy.
Okay. Well, just last slide here, overgoing what we already discussed here, that the biomarkers in prostate cancer, if they're developed with a specific clinical scenario in mind, it might help increase the time for their clinical applicability, as opposed to being described but not actually brought to any clinical relevance. Early disease is probably best assessed in blood and urine, which are readily available, and late disease may be best assessed on tissue assays when tissue is readily available. Again, the development of biomarkers is a very difficult topic. They're easy to describe, hard to make clinically relevant, and widespread adoption of any particular biomarker is usually slow to occur. And the main issue here that I wanted to focus on was how tools are being used to prevent overdiagnosis and overtreatment to reduce the risks associated with those, and how things are moving towards what seems to be a patient-centered and individual patient-centered management strategies. Thank you.